Welcome to Learning Plan 8. We are going to be talking about the GI system. Antacids, antidiarrheals, antiemetics, everything to do with the guts. So let's get right into this and start learning about what we're going to be talking about. 60 to 70 million Americans are affected by a digestive disease. That's like 22% of everyone. So in this room, we're looking at probably 5 or 6 people right now have a digestive problem. That's a lot of people. 13% of all hospitalizations are related to digestive disorders. More than 40% of all ER visits are because of abdominal pain. Now, it's not necessarily digestive, but a lot of times it is. It's amazing how many people go to the ER because they're constipated. So this is a really big deal for things that are very controllable. We can control a lot of the problems associated with our GI systems. So let's figure out what we can do as nurses, as people, and what we can help teach so we can prevent some of these ER admissions, some of these hospitalizations, and generally make life a lot better for people. Peptic ulcer disease, or PUD, it's a lesion, an irritation, and erosion in either the stomach, the gastric, or the small intestine, the duodenum. Now, the parietal cells secrete 1 to 3 liters of hydrochloric acid each day, and this is how we digest food. This is also the primary site of many acid-controlling drugs. The strong acids are used to break down food and microbes that may have been digested, so they're a protection. And the average pH of the stomach is 1.5 to 3.5. So why doesn't this acid just like dissolve us? Well, inside the stomach, it's coated with a mucus layer, and that mucus layer helps neutralize the acid, as do bicarbonate ions. So there's a protection on our skin inside that, so the acid focuses on the food. But when that mucosal layer is thinner or absent, obviously that's when problems develop. So we'll be talking about ways to protect and support that mucosal layer, ways to reduce the acid production, and then other ways of just improving the entire process. So when there's good blood flow to the cells of the GI mucosa, everything is maintained properly. The tissues are healthy. They produce the bicarbonate to protect themselves. They produce the mucus. But sometimes things get into that and disrupt the whole healthy process. And a major bad actor is a bacteria called H. pylori, or Helicobacter pylori. We're just going to say H. pylori. This is a gram-negative bacillus, and it can colonize the stomach and duodenum. Why this promotes ulcers is not been firmly established. It could be enzyme degradation. It could be an enzyme that forms carbon dioxide. But really, we don't know why the bacteria promotes ulcer formation. We just know that when the bacteria is present, ulcers are more likely to be found. Excuse me. So we need to find a way of getting rid of H. pylori. That's a major aggressive factor. NSAIDs, ibuprofen, naproxen, aspirin. These inhibit the synthesis of prostaglandins. They decrease blood flow, and they suppress the secretion of mucus and bicarbonate and promote the secretion of gastric acid. So if you take ibuprofen for headache or for long-term use, you are stimulating more acid production, at the same time decreasing the production of mucus and bicarbonate. So that's a double whammy on increasing your likelihood of having a problem. injured cells of the GI mucosa, it activates pepsin, which is an enzyme that dissolves protein. There's a syndrome called Zollinger-Ellison syndrome. It's a hypersecretion of an acid. It's a tumor that secretes gastrin, which is a hormone that stimulates gastric acid. Smoking. I hope none of you smoke. But if you do, you need to remember that smoking delays healing of an ulcer and increases the risk of reoccurrence. It also reduces the beneficial effects of anti-ulcer medications. It reduces the secretion of bicarbonate and accelerates gastric emptying, which delivers more acid into the duodenum. So smoking has many, many risk factors involved. Diet plays a very minor role in ulcer management, believe me. Bland food, milk, cream, it doesn't accelerate healing. There's no convincing evidence that caffeine-containing beverages promote ulcer formation or interfere with recovery. However, 5 to 6 small meals a day can reduce fluctuations in the gastric pH. Stress, anxiety, alcohol, there's no strong evidence that those play a role in ulcer formation, but if we can control those, think of everything else that we won't need. If you have stress, you're going to have headaches. If you have headaches, you might take ibuprofen. If you're anxious, you could take all sorts of stuff, including alcohol. So while there's no evidence that stress, anxiety, and alcohol or caffeine cause problems, they can lead to conditions or situations that can bring the problems on. So let's try to control those whenever we can. So gastroesophageal reflux disease, GERD. In a normal flow of food, you eat food, it goes through your esophagus into your stomach, the stomach starts digesting it, and then it empties into the duodenum, and it goes through the small intestine. In GERD, we're having reflux or backward motion. And so stomach contents, food, acids, move up into the esophagus. This causes intense burning. It can lead to ulcers in the esophagus. It can lead to esophageal scarring. GERD happens when the lower esophageal sphincter is weak. The sphincter may no longer close tightly, which allows the stomach contents of the stomach to move upward when the stomach contracts, and the stomach is supposed to contract. GERD is also associated with obesity, and losing weight may eliminate many or all of the symptoms. And personal story, when I lost my weight, my GERD symptoms went almost completely away. It's very rare now, and I'm very happy for that. Many of the drugs that we use to treat peptic ulcers are also used to treat GERD. We're trying to reduce the amount of acid that's present. Doesn't stop the food and acids from moving up into the esophagus. It just reduces the amount of acid that's moving up there. So that's GERD. GERD in and of itself, the backward movement of the foods and acids, that's an indicator of either another problem, sphincter weakening, or a hiatal hernia where part of the stomach has moved up above the diaphragm. And it leads to further problems. As I said, the esophageal scarring, strictures within the esophagus, and just general pain and misery. If you've ever had bad heartburn, you know what I'm talking about. Before we start drugs for this type of symptom, we want to teach lifestyle factors and change lifestyle factors first. Whenever we can prevent the use of a medication, it's better. Because medications have side effects. We've talked about all these side effects on all these medications. So if we can change lifestyles, we can eliminate another medication and those side effects. So what are some things where we want to change? Well, first off, tobacco. Stop using tobacco. It has those very negative side effects. Alcohol use. Now, I said alcohol is not proven to be a causative agent, but alcohol is a very irritating substance. Alcohol is very corrosive to the skin. So if you're having problems with your stomach and you're drinking alcohol, it makes sense to stop. And if you can reduce stress. Again, stress leads to other physical symptoms that you may take over-the-counter drugs to treat, and those drugs can cause GI problems. When we do prescribe medications, our goals are to provide immediate relief of the symptoms, promote healing of an ulcer if present, and prevent future reoccurrence of the disease. So immediate relief, healing of the ulcer, prevent future reoccurrence. And we have a lot of different medications to work with. We have antacids for immediate relief. We have antibiotics to promote the healing of the ulcer and to get rid of the source of that potential ulcer. And then we have acid reducers, H2 receptor agonists, and proton pump inhibitors. We'll be giving a lot of those in hospitals. And we have mucosal protectants. We want to protect and support that mucosal layer on the inside of the stomach to protect it against that acid. So we have a lot of different types of medications we're going to be using. We'll be talking about all of them in this part of the lecture. Antibiotics. So why an antibiotic for ulcers? Remember we talked about H. pylori, Helicobacter pylori. It is frequently found in people that have duodenal and gastric ulcers. Not always, but it's common. H. pylori is it's a gram-negative bacteria. It's associated with 90% of ulcers and 90% of duodenal ulcers and 75% of gastric ulcers. It's also strongly associated with gastric cancer. And this bacteria is unusual. It has adapted to a very high acid environment. High acid also means low pH. So it sticks to the GI mucosa. And it can remain active for life if it's not treated appropriately. We need to eliminate this organism to treat ulcers more rapidly and to remain in remission longer. So we have to get rid of this bacteria. How do you get rid of a bacteria? Antibiotics. And a lot of times it takes 2 or 3 antibiotics to prevent H2 resistance. Amoxicillin is a common one, Biaxin is one, and Flagyl. Those are 3 common antibiotics that are used to eradicate Helicobacter pylori, H. pylori. Without antibiotics, H. pylori will not go away. And if H. pylori doesn't go away, ulcers will eventually return. So that is why we use antibiotics for ulcer prevention. Why don't you come back in the next section, we're going to talk about the H2 and H2 blockers and PPIs.